All right, let's jump right in. Today we're going to be talking about two conditions that affect millions and millions of people, but are so often misunderstood, misdiagnosed, or just flat out dismissed. We're talking about endometriosis and PCOS, the unseen conditions. You know, for so many people, the experience of truly debilitating pain just gets waved off. They're told, oh, it's just a bad period. But as we're about to see, what we're talking about today goes way, way beyond that. And just to give you a sense of the scale here, endometriosis alone is thought to affect up to 1 in every 10 women of reproductive age. So think about that for a second. In any room with 20 women, there's a good chance at least 2 of them are living with this, whether they even know it or not. Okay, so let's start with endometriosis. The name itself can be a bit of a mouthful, I know, but the core idea behind it is actually pretty straightforward. I kind of like to think of it as the inside-out problem.
So, the official definition sounds simple enough, but the reality is so much more complex. Imagine the lining of your uterus is like the soil in a garden. Now, with endometriosis, it's like that soil has somehow been scattered outside the garden walls. It's ended up on the ovaries, the bowels, maybe even the bladder. And every single month, it tries to do its job and grow right there, which, as you can imagine, causes a ton of inflammation, scarring, and, of course, a lot of pain.
And that constant inflammation, it leads to a whole list of symptoms that are just not typical period cramps. We're talking about dysmenorrhea, which is the medical term for severe, life-disrupting period pain, or dyspareunia, which means sex is painful. It can even show up as chronic low back pain or make going to the bathroom incredibly painful. And this is a big one. The impact on fertility is just staggering. Endometriosis is a factor for up to half of all women who are struggling with infertility. So how in the world do you find these little bits of tissue that are growing in the wrong place? Well, an ultrasound can give doctors some pretty good clues, but it can't actually confirm it. The only way to know for sure, 100%, is a laparoscopy. That's a keyhole surgery where they can go in and physically see the tissue. But surgery is a big deal, right? So very often, doctors will go ahead and start treatment based on symptoms alone just to get you some relief as fast as possible.
Okay, let's switch gears and talk about our second condition, polycystic ovarian syndrome, or PCOS. Now, while this can also involve painful periods sometimes, it's a totally different kind of problem. See, PCOS isn't about tissue being in the wrong place. It's a syndrome, which means it's a whole collection of issues all happening at once.
So where endometriosis is what we'd call a structural problem, PCOS is a hormonal one. In fact, it's the most common endocrine disorder for women of reproductive age. You can think of it like a miscommunication in your body's hormonal messaging system. This miscommunication leads to an excess of androgens, hormones like testosterone, which, by the way, are totally normal in women, but in PCOS, the levels are just out of whack.
So, how do you diagnose this hormonal miscommunication? It's not as simple as a single blood test. Instead, doctors use something called the Rotterdam criteria. And really, it's just a 2 out of 3 rule. To get a diagnosis, you need to have at least 2 of these 3 things: signs of high androgens, like acne or excess hair growth, irregular or even absent periods, and finally, polycystic ovaries that are seen on an ultrasound.
Now, this next point is so important because it really gets to the heart of the single biggest myth about this condition. Even though polycystic ovaries is literally in the name, just having them show up on an ultrasound does not automatically mean you have PCOS. And the data really drives this point home. You can just think of it as the rule of 20. About 20% of women who are diagnosed with PCOS don't actually have polycystic ovaries. And on the flip side, about 20% of women without PCOS do have them. So you see, it's just one possible feature, not a requirement for the diagnosis. And this is why getting that diagnosis is so critical. Because these hormonal issues, they lead to a whole cascade of effects. Let's connect the dots. You've got high androgens. Well, that's not just about acne. It can directly affect fertility. Then there's insulin resistance. That's linked not just to weight gain, but to a really serious long-term risk of type 2 diabetes. And finally, those irregular cycles. They aren't just an inconvenience. Over time, they can actually increase the risk of endometrial cancer. It is all connected. Okay, I know hearing all of that can feel pretty overwhelming, but here's the crucial part, and it's really important.
While there's no simple cure for either of these conditions, both of them are absolutely manageable. The goal isn't some one-size-fits-all fix. It's about finding a personalized path to manage your symptoms and lower those long-term risks.
For endometriosis, the treatment path really depends entirely on your goal. It's like a fork in the road. If the main goal right now is fertility, then surgery to actually go in and remove those lesions is often the focus. But if the goal is just about controlling symptoms and getting your life back, the approach shifts to hormonal treatments that are designed to suppress the growth of the lesions and manage the pain.
And the management for PCOS is also very targeted. Let's take hirsutism, for example, which can be one of the most distressing symptoms for a lot of people. The medical approach is usually a logical, step-by-step process. Step 1, direct removal, things like waxing or laser. Step 2, you attack the problem from the inside with hormones to lower those androgens. And step 3, if that's not enough, is adding a specific anti-androgen medication. It's a really logical, escalating therapy.
And beyond just medication, we can't underestimate the power of lifestyle changes in PCOS. This statistic, honestly, is incredible. For overweight patients losing just 5 to 10% of their body weight, that small change can be enough to restore regular ovulation in over 80% of cases. That is a huge, huge impact from something that doesn't come from a pharmacy.
So we've covered a lot of ground on these two really complex conditions. What's the bottom line? What does all of this really mean for you? Let's boil it down.
If you only remember one thing from this entire explainer, please let it be this. This is the fundamental difference. Endometriosis is a structural problem. Tissue is physically in the wrong place. PCOS, on the other hand, is a metabolic problem. The body's hormonal systems are out of balance. Understanding that one distinction is absolutely key to getting the right diagnosis and the right treatment.
Look, the journey with either of these conditions is unique for everyone. It's complex, but advocating for yourself or for someone you love, it all starts with knowledge. It starts with being able to walk into a doctor's office and have an informed conversation. To push for answers. We've given you the understanding. So the only real question left is, what's your next step going to be?